Hey, welcome to Crisis in America, PTSD and veteran suicide. Hey, I'm Colonel Mike Brown, United States Army retired, and I'm here with some special guests today. This is going to be our first live video panel discussion on mental health, specifically with our veterans and service members. With me today, I have Dr. Nagy Youssef, I have Mr. Andrew Canales, Miss Amanda Allen, and Miss Jan Freeman. And we are going to have this panel discussion today and have some topics of discussion, and then we'll go into some questions, and then we'll go ahead and conclude. But I'm really excited to have this panel today. Mental health is very a big concern, as well as physical well-being and spiritual well-being amongst our veterans and service members, with 22 service members each day committing suicide in veterans. And also that is over the last 12 years, 2 decades now going on, actually our third decade going on, is over 96,000. We have lost over 96,000 men and women who have proudly served their country, only to come home to a invisible wound, or even a wound of war that has become so overwhelming that they cannot see any other way out of suicide. So join me here today. I want to go ahead and let the guest panelists introduce themselves, and we'll start with Dr. Nagy Youssef.
Thank you, Mike, and thanks all. Nagy Youssef, I am a professor at the graduate school and clinical professor at the medical school at the Medical College of Georgia at Augusta University.
About Mr. Andrew Canales. Thank you, Nagy. Dr. Nagy.
Hey, thanks, Colonel. Andrew Canales, Air Force veteran and founder of Houses for Warriors, where we support homeless and injured veterans with as much support as we can.
Great. We're so glad to have you aboard. Can't wait to hear your insights. Miss Amanda Allen.
Hi, guys.
Hey, Amanda.
Amanda Allen.
Hey, Amanda.
My jewelry name is up on the screen, Bead Pricks Jewelry. I make jewelry as art therapy. I was Army, military police. I got out in 2013, Afghanistan, Operation Enduring Freedom, 2011, 2012.
Great. Can't wait to hear you as well, Amanda. Thank you for showing and being present today for this very important topic. Hey, Miss Freeman.
Yep. I'm Jan Friedman. I have been involved with veterans for the last 4 years of my life. I'm very active in the local community here as much as I can be, and I support veterans in every which way that you can imagine. And I am proud to be part of this group. Thank you so much.
Thank you, Jan. And we know you have a lot of personal insight and with crisis within your family, and it's going to be great hearing you as well. So welcome, America, to Crisis in America, PTSD and veteran suicide show. And today we are going to talk about mental health. Now, we're a fair and balanced show, and we're not concerned too much about political opinions. It's the hard truth, and one purpose right now is to reduce these suicide rates amongst our veterans and first responders. And we do this by having guests like we're going to have today, and who can address these issues that we're going to talk about, talk about topics today, and offer solutions. Now, we know here as the panelist and myself, and just to inform the greater part of America, the co-occurrence of PTSD and moral injury and TBI and depression with our returning warriors, it is also curtailed with substance abuse, is going to require us all to have innovative ideas to provide these optimal solutions and treatments. There are so many that are out there right now, some evidence-based, some based on personal observation and witnessing, and we're going to talk about that as well. But one thing is the reason we came onto this summit today and are having this panel is that we do believe that we haven't done enough. Why? Why haven't we done enough? How can I make such a broad statement? Well, the statement is based on the fact that we haven't curtailed the suicide rate for over the now going on 3 decades. It's the same. And this last couple of years, it's actually the last 3 years, it's been increasingly higher. And we know we need more local attention being placed on this epidemic, which is plaguing this nation. It is an epidemic. And therefore it continues to raise concerns. It should be on the front table for all discussions, I believe, that include service members and veterans. Now, we had over 7,200 veteran suicides each year from 2008 to 2020. And one in returning veterans, and this is a big number we're going to get into today as well, are affected by these invisible wounds of war, which I classify in. And we have Dr. Nagy Youssef, who is definitely a subject matter expert in this area, PTSD, moral injury, depression. And we know that there is a shortage of clinical care providers available to deliver even evidence-based treatment. That's why we also have nonprofits on here today to discuss what they're specifically doing in their area of operation to curtail this. And we also know that spiritual treatment, and we're going to talk about spirituality today in a sense of a treatment modality. Each day when we look at these young males and women under the age of 30 are 3 times more likely to kill themselves than their peers. It's startling. And we're going to go through some specific statistics today as well, just to frame the discussion for you when you go to your community leaders, your state leaders, and your national leaders, to be able to more frame it into concrete, measurable things. And I think that's going to be important and an important topic to talk about as well. Now, we know this is unacceptable. We know that we can't continue on the way this epidemic is going. And we know it's a crisis, largely ignored. And I'm sorry, but I told you up front, we're fair and balanced, and we don't sugarcoat here on this show. That suicide numbers haven't changed, right, for the last 3 decades. And with the return of over 2.7 million veterans, often in wartime zones like Iraq and Afghanistan. We have 2 today that have been in either or theater. So we'll have some firsthand experience on what combat looks like. And I think it's fair to say that it is our solemn responsibility. It really is, to care for our returning heroes. And it's got to be the mission, top mission. You know, we're getting ready to pull out of Afghanistan. All those soldiers, sailors, airmen, Marines, Coast Guardsmen are going to be out on September 11th, 2021. That's a huge number coming off the battlefield all at one time. And America's going to have to embrace that and the challenges that come with it. Now, regarding the suicide crisis that has endured, and it has markedly increased, as I mentioned already, we have a stark reminder to redouble our efforts. And when I say redouble our efforts, what I'm looking at is it needs to be inclusive. It needs to be holistic treatments. It needs to bring the medical community together with the spiritual community and impacts on local leaders. So the topics today are as follows, and I'm just going to read the topic question, and then we'll have our panelists who want to address that question up front. So, you know, one of the biggest issues we are seeing, and these are 3-ish topics we're going to talk about. We're going to talk about transitioning from a veteran service member's perspective to a veteran status. Or 2, we're going to talk about spirituality and other modality trainings for treatment. And 3rd, we're going to talk about a little bit about the legal aspects of all this and why our national political system is important. Our diplomacy is important. How is the democratic and the republic process is important. So, but the first topic is this. One of the biggest issues we are seeing amongst our active duty, guard, and reserve, and those that are coming out of service, is when the service member is getting ready to make that transition from his active perspective whether that's on guard or reserve, I'm just classifying it as that, into civilian life. Largely because they do not get their VA disability while they're going through this transition period. Therefore, in the first 1 to 3 years of separation, the suicide rate is the highest amongst those that have been diagnosed with mental illness. And that number has been reported at 33%, with some studies, recent studies, and we'll talk about that in our statistics, up near 50%. And if you take a personal view, some of those have been up to 82%. So one of the most important aspects of suicide prevention amongst our service members and veterans is ensuring ongoing medical care. It's got to be that way. And during the transition, this is when the suicide risk is the highest. Between the first year and third year, that's when they're killing themselves coming off. So we know it's a very critical problem. We also need to ensure that ongoing access to counseling, coaching, and assistance in finding new mental health providers is always ongoing. So here's the question based on this topic discussion. What can we do to mitigate the suicide risk during periods of transition? And that, again, that period of transition is coming from active duty to becoming a veteran. Would any of the panelists like to address this question?
Well, I think it's very important, Mike, as you stated, the connection to service. This is a big topic, I'm sure, at the VA and also at the military. And the thing is, I think everybody before, during, and after, if they have any kind of problem, whether social, medical, or otherwise, from a mental health perspective or otherwise, should be connected. I mean, I'm not an expert on the disability at the VA, but I'm understanding is that service members also can access through the military, or also go outside, see providers outside. You know, this is a hard topic a little bit because usually it's preferred that they are within the system, but I think it should be made easier where people can see if there is not enough providers. So for example, the military have only 100 psychiatrists, the whole military.
That is incredible. I didn't know that.
That's definitely not enough. The problem also is, I always tell the patients that, for example, for PTSD and to some extent for depression, but you know, cognitive therapy or psychotherapy, different forms of psychotherapy or cognitive processing therapy, prolonged exposure is 70% of the treatment if they have PTSD symptoms. It's the most important. It's not medications. But on the other hand, sometimes medications is required, and that needs a psychiatrist. The other thing is there is sometimes comorbidities that needs medication. For example, bipolar disorder is a very biological, and it's a real problem. Sometimes depression, you know, with certain severity will need medication. So having 100 psychiatrists is not enough at all. And so there should be a system where the transition is more smooth. There should be some educational system to anybody, whether they have a mental illness or not, of how to transition, which can be education, but also counseling. That includes counseling on how to do that, and also how to increase resilience. I think increasing resilience, and there is programs now in the military for improving resilience. I think it should be before joining, but also while separation. The thing is, PTSD or even symptoms without a disorder, a lot of it is due to certain areas in the brain that's hyperactive, which allow us to fight at war, like the amygdala and certain areas of the limbic system. And this is hyperactive, makes people having symptoms, have flashbacks, not able to sleep, and all that. And to almost wind down that, it needs also a program to help with that transition from a psychological or a counseling point of view. But again, it's really important to connect people if they need a psychiatrist to connect with that. That will help the disorders, but also help decrease suicide rate. Because part of the suicide, the thing is I see a lot is that sometimes it's assumed that suicide is only psychological or only social, which big part can be, but there is a biological aspects too. For example, suicide can run in families. There is genetic loading, and sometimes medications are needed. There is some medications that can decrease suicide impulses. And so while I'm very pro counseling, psychology, and spirituality, but I think it should be addressed as a holistic, from a holistic point of view, to address all aspects. And not everybody's the same, so it should be also individualized.
Thank you. Thank you, Professor. That was a great insight to the ongoing, is what I heard. It should be an ongoing mental health process from beginning of entry into the services, through the service, and then continue on outside the service. That's what the good model should look like. The great gold standard model should look like. Unfortunately, those are things that I love having these panel discussions about, because we can pass your discussion, Dr. Youssef, into America, into those that can create change. I'm specifically talking about service secretaries and the chiefs of all the services, as well as the Department of Defense, Defense Secretary, and as well as the VA Secretary. These are great insights to change the model, because your current model is not working. Let me just give a stat here real quick, just to put this in perspective, and then we'll ask Amanda and Andrew to chime in. Here's what it looks like. And this is a survey of over 36,000 veterans who have served in war, specifically in the 9/11 era. 93%, this is self-reporting, folks. All right, you have reported, you have non-reported, and then you have self-reported. This is from self-reported. 93% live with a mental health condition. Military. It doesn't go away. Of that 93%, the top four are PTSD at 83%. You have anxiety, which is at 77%. Third, you have depression, which is at 72%. And then fourth, you have traumatic brain injury. Those are startling numbers. One guest that we had on our show, and we talked about this, is what can we do at our local levels? Well, this Sharon Kennedy, Justice Sharon Kennedy, the Honorable Kennedy of the state of Ohio, expressed that she was sick and tired of seeing with Ohio, which is the sixth largest veteran population in the United States, by the way, coming home and having suicides on her watch. She was seeing it through the court systems, and she has a program called Lean Forward. And basically, in a nutshell, is you don't come back to your home station, your retirement station, unless you're picked up by healthcare. And between her and the judges and the human services departments and local communities, they have a program called Lean Forward. And that is it's kind of like a welcome wagon at each community. And each community will get a reception of that veteran when he or she comes home. And at that time, the community will embrace and ensure mental health care access is present. Now, it doesn't stop the whole holistic gold plated standard, but it's a start. If you can't see the change now, what can you do in the interim? And this welcome home, welcome wagon kind of methodology that is being used in the state of Ohio is a great way to connect that serving service member to his or her community when they get out, and ensure that there's a conduit of treatment beforehand. So that's one area going on. Andrew, what do you have to say?
Well, like Dr. Youssef said, the mental health and the holistic treatment needs to start be ongoing, and actually from start to finish of that transition period. But one thing that I'm not very clear of, and that doesn't really get asked a lot, is how many of these suicides had an unfavorable discharge, and how many of them didn't recognize the behavior that got them discharged in an unfavorable way, in an other than honorable way. Was that directly related to the mental health issues and the PTSD or other issues that they've had? Because I know when I was in, you mentioned that you're thinking about suicide, you're straight into the mental health clinic. They strip you of your job, and they start kicking you out. They start pushing you out on a med board. So there are some people that are lucky enough to, admit that they need help, and they go through that process and they get the scrutiny, and then they get the help right away. They get straight into the VA. They get their disability, they get their med board, and they're sort of, supported and taken care of through that transition, as opposed to the other guys who avoid that, who self-medicate, who smoke pot or do drugs or get a DUI, and then they're on the other end of the spectrum. They are not looked at as somebody who's sick. They're looked at as a dirtbag, and they're pushed out, they're forced out, and they're kind of kicked to the curb to fend for themselves. They don't know about the disability. They don't know about the benefits. They don't know about any of that stuff. And then, so in that first 1 to 3 years, how many of these, we're not addressing the issues from the start. We're addressing them too far down the road. And I know that the majority of the veterans that I encounter in the homeless community were kicked out, or they had drug problems, or they had issues that just went unrecognized and completely avoided treatment because of the stigma attached to suicide. And I think that has a lot to do with it. And so exactly like Dr. Yusuf says, it needs to be from an ongoing treatment, but we need to recognize when the beginning of that is at the start. And when they actually need it, instead of, and I've talked about this on your show in the past, like since 2017, they've actually recognized that, some of these discharges might have been because of the PTSD, or directly related to, the mental illnesses because of, the drug seeking behavior. And so they're actually going back and changing these discharges. But, how is it, it's too late for a lot of these guys who've already taken that final step. So that's my kind of perspective on this. And I think that the military, active military, needs to do a better job of recognizing when these guys are getting in trouble, when they're not following orders, when they're, slipping, that there might be something else going on. They're not just dirtbag, but they might be suffering, especially if they just got back from tour. We see most of the DUIs and most of the trouble happens when they get back from country. So I think that it's kind of obvious for me when I talk to these guys. So
yeah, that's great insight too. And I think what I heard, and it's something we should talk about, is the legal aspects. If we are discriminating healthcare based on discharge, then we're doing a disservice to this nation. So you're right. Other than good conduct, honorable conduct, even bad conduct, there is conduct for discharge for bad behavior. True statement. Andrew's all over it, man. And it is, I'll give you a stat that I am familiar with. It's 4 times higher. We are bad conduct discharging these folks than any other war. Specifically, World War II was the pivot point there.
Much harder to get a job after a bad conduct discharge and maintain your livelihood.
That's right. And it's one of the most commonly reported. I've heard right now standing numbers near 500,000, somewhere in that figure, with bad conduct discharges, which America just, you know, as we talk about this legal aspect Andrew's bringing up, in this discrimination, I call it, you're discriminating and you shouldn't discriminate. Just because you need to, I got the murders and I got the sky stuff that's way up there. It's a no-brainer. But missing drill duties, maybe getting a fight in the parking lot, or cussing out a subordinate or superior, or some other
Self-medicating.
self-medicating, self-reporting. You know, you've been heard of, and I've heard this, and we've had stats on this legal aspect. Self-reporting could end up with a other than honorable discharge. It's crazy. We need to change that. I think that's where you were alluding to, that has to come out as a discriminator, because it is, and it'd be nice. Data means everything. Andrew, you know it as well as I do, as well as Amanda does, and well as Dr. Youssef does. Data tells you the story. Now you have to use that story, making it actionable information, so to create knowledge. So let's do a little bit of creating knowledge here. The actuality of this problem, of this legal issue and discrimination, we just told you the statistics that we have. What's worse about it, we don't have the data set Andrew just asked for that states how many of these suicides were bad conduct discharges, which they were denied services, I'd imagine, from any VA or private sector. It's a great question.
Well,
What do you think, Amanda? Oh, go ahead, Andrew. Go ahead.
Sorry, I just wanted to add one thing too. You know, I don't want to say this in a way that makes it seem like I'm saying these guys should avoid responsibility for, you know, misconduct. Sure. However, you know, there is, like Dr. Youssef said, we have to actually diagnose these treatments at the start. It was just my kind of last point, and I'd love to hear what Amanda thinks about what I just said.
Real quick before we go to Amanda, and that's a great point. Thanks for the reminder. I love panel discussions. You can always, especially for us old guys who forget things, you bring a good point up, you know, and the point is that, you know, we don't condone bad behavior. That's a great point. But what we do, should, and continue to focus on from this legal perspective is that I'm trying to get it pinned down to the right words here so I don't misconstrued, but in legislative act. So there's a law out there, can you believe it or not, about how a VA can translate a discharge coming off active duty or guard reserve. There's a law. I can't remember the law's name right now, but the VA, for medical purposes only, can change the designation of their discharge or take the discharge itself and reclassify it to good conduct honorable. They were given that by Congress. So I think there's a mechanism in place. I don't think it's being used. I could be wrong, but it goes back to what Andrew says. Where's the data set that shows the impact of non-honorable or good conduct discharges, other than honorable discharges, are impacting on the mental health? And remember, we're trying to reduce the suicide at all costs. And we haven't moved the number, not even one digit. Amanda.
Andrew, you took the words right out of my mouth, I swear. You did. With my personal experience with my soldiers, with the National Guard side of things, you're not eligible for VA benefits if you don't deploy or if you're not injured in training. And then, like you said, the misconduct or the behavioral issues that cause, or the drug issues that cause the bad discharges, there is no data on that. There is no data on that. There's not any data saying this percentage of these veterans to fix that. Well, we're not doing anything to fix that because I don't think that anybody's looking at it closely enough. I know personally soldiers and family members that have had the unfortunate, they have bad discharges because they were not helped when they were in or getting out. They had issues with drug problems because they were self-medicating from the issues that happened to them. I'm not going to go into the detail, but it has to do with military sexual trauma. It has to do with racial discrimination. It has to do with hazing and bullying and stuff like that. So when you look at all of those things and you put it into perspective alongside all these soldiers with discharge codes or that cannot get the mental health care that they deserve because they didn't deploy. So does that mean that they're not good enough to have this health care and us that have deployed are? Because I don't think that should be the case. I think that we volunteered to serve. All of us volunteered to serve, all right? You went and you signed that dotted line. You made that oath to your country, to God, country, and all of citizens. You fought for them and you fought for this country. So in my mind, I mean, there's some bad soldiers. There's some bad apples out there. We all know that, and we've probably all seen it. So obviously, there is some people out there that don't deserve the benefits due to their own personal choices and refusing to do what they need to do to get better. But this leadership that's giving these people these bad discharges, what are they doing? Are they just giving it to them because of what they don't want to look into it deeper? Did they talk to the soldiers' battle buddies? Did they talk to the soldiers' leadership and see what their character was and is, and see if maybe you could get anything from these battle buddies saying, yes, this soldier, they're great. They're just struggling this one thing, this one thing. If we could get help with this one thing, everything would be better. But they tend to be pushed to the side, or they decide that they don't want to say anything because they're going to get judged, or they're going to be looked at differently by their peers, by their leadership. They're going to get bad discharge code. They're going to get med boarded out because they're crazy or anything like that. I'm actually dealing with trying to get a discharge code changed because of this. Because
Me too.
Because this person didn't deserve this 20 years of not having the health care, dealing with depression, horrible depression, horrible medical issues, service-connected issues, surgeries that the military promised that then they just didn't give it to them. They just sent them out to sea, just canceled the surgery, sent them out to sea, kicked them out. So I think that the leadership, all the way to the top level, they need to be looking at these things closer. Because one big thing that I have had and I've been carrying with me and I've been preaching to other people is look at these people with the bad discharge codes, see who they are. You need to know who they are.
Definitely.
Yeah, I think what you brought up is another key topic in leadership.
Mm-hmm.
Now listen, and as a prior leader, you're a prior leader as well, Andrew. And everybody has a leadership role in their own area of expertise. Dr. Youssef, you're the same. What is the leader's responsibility? And that's a rhetorical question. What I'm trying to state here is leaders in the military right now, what I'm hearing from you, Amanda, need to take more of a holistic approach prior to giving them a discharge status. Now, as a prior brigade commander, I would take into consideration, you would do this on the civilian side too, take in consideration the individual person, and understand that if it was a medical condition induced by a medical event, so let's say PTSD on the battlefield, then that changes things. Why does it change things? And I'm going to ask another make another statement real quick. When did we start using medical as a punitive punishment?
Well, I'd say we have to assume that the leadership in active roles of the military aren't going to do that. It's not the holistic approach. So it's going to fall on programs and mentors. Yeah. Truly, there's a program I'm partnering with called Warrior Now in Colorado. They actually assist in a supportive role while these guys are going through court and going through the legal battles. They bring them coffee, they bring them emotional support, and a place to, they're working on a place where they can go and have like a community space. And then they also do suicide prevention training to their mentors by clinicians that are trained and certified. And essentially they're creating a mentor base, so that all my, like for instance, all my homeless veterans who are really high risk for suicide, they're all, when we get them off the street, they're going to get attached to a mentor, a one-on-one mentor, someone who can help them, you know, navigate this VA system and navigate the benefits, navigate that discharge upgrade. When what you were talking about, Colonel, is that CURTA memo of 2016.
That's it.
That they take liberal consideration for PTSD and mental health if you were seeking drugs or behaving in a way that was in misconduct to our rules. And so it's, you know, they are working in it, but it's how many people actually know about the CURTA memo in 2016? Like that we have, it's an education, you know, we're at a wall of knowledge and nescience where people just don't have the knowledge, or they don't know the process to navigate these upgrades. And if we can catch them before they're transitioned out of the military, if we can catch them at the beginning of this transition and educate them while they're going through these legal struggles, I think we could actually, you know, prevent these these suicides 3 years down the road. That if they didn't get the support and the help they needed while they were in, you know, it can absolutely lead to, you know, joblessness, which leads to homelessness, which leads to depression, which could lead to suicide. And then that's what we're seeing. It's you're 1 in 5, you're 5 times more likely to commit suicide if you experience homelessness as a veteran. So that's huge. We actually need to, you know, educate these guys before they get out on what their rights are. Because they do have rights to challenge and fight these decisions at the beginning and appeal it, and they can absolutely still qualify for disability even with an other than honorable discharge. And they can still qualify for healthcare. We all qualify for healthcare, so there's no excuse to not be in the system. And most of these suicides we get are, you know, we got 40% of the suicides that aren't in the VA system at all, or is it 60%? It's between 40 and 60%. It's a big number.
I think it's at least 40. I know that statistic is true. Yeah. Some will say it's higher.
It's conservative for sure.
Yeah, definitely. Jan, welcome. You have some personal perspective of transitioning from the military with your grandchildren, do you not? Can you give us some insight there?
Well, I have 2 grandchildren that were in the military. I have a granddaughter who served and who was injured during her time in the military. Unfortunately, after she was honorably and medically discharged, she found that she had all these injuries that were not being treated, that were not being cared for. And so she struck out on her own with the advice of her commanding officers to get some treatment here in Colorado. These places were not all sanctioned by the VA. And as a result, she ended up with over $100,000 in medical bills. Yeah. I worked with her for 2 years to try to get the VA to see where it was broken. How did it get so broken that she who served is now responsible for all of her medical bills? And she is still needing further treatments. She needs surgery on her foot. She's had surgery on one hip. She needs surgery on her knees. She's 27 years old. and she has a broken body and a responsibility to pay bills that are running after her. It's a travesty. It should not be. So that's one grandchild. And then I have a grandson who was in the military, and he was one of the 22, and he committed suicide when he was 19. If you've lost a grandchild or a child, you know how devastating that can be. There is never any answers. That person has decided that he's going to take a permanent action for a temporary situation, and he's never around to answer questions. So those of us that are left are in pain forever, trying to find out why we didn't know, what happened, how come we didn't ask the right questions, did we have signs? We don't know. It's something that weighs on your soul and your heart for the rest of your life. And I'm without my grandson now because of that. So those are the two situations that really flung me into working on veteran affairs, veteran situations, trying to help veterans in any way that I can.
That's great, Jan, and God bless you and your family and the sacrifices of your grandchildren and, of course, your grandson's passing. We continue to mourn that and put you in our prayers for that.
Thank you.
You know, America, you're hearing today a panel discussion on mental health issues related and physical health issues, but specifically mental health we're talking about today. What we have today is our guest panel, Dr. Youssef, Andrew Canales, Amanda Allen, and Jan Friedman here addressing these questions. The question we're talking about here today, if you're just tuning in, is the prominence of mental health issues that continue to create issues amongst our serving and retired folks. I'm going to throw some things out, and Amanda kind of sparked my interest here on this one when she was talking about, and I think all of us can coincide with these same ideas or same thoughts about what are the barriers, what's happening right now with this thing going untreated. Well, first of all, let's go back to the stat. 30% of all warriors that were reported in this survey that we're using as a reference point today out of the Wounded Warrior Project, which is the largest nonprofit in the United States and the world for this specific topic, reported 30% of veterans have thought about killing themselves. That's a big number. 29% had difficulty even getting health care. And going back to Andrew's number, probably 40 to 60%, 40 being conservative, don't even seek care. So what does that do? And what does it do with the legal means? And what Dr. Youssef has talked about, the right treatment at the right time. You know, personal schedules, work, family, conflict with hours of operations of VA healthcare, all these things impact access to healthcare. So if you don't get the healthcare, then unfortunately, you're going to be part of that 22. I can almost state that with a pure confidence level. Seeing what I'm seeing. Go ahead, Dr.
If I may, Mike, I want to stress two things. One is access to healthcare, and that needs, to be improved a lot. Obviously, there is a problem with that because there is not enough psychologists, social workers, psychiatrists, whether at the VA or even more in the DoD. But the other thing is that I think is very important, and I'm not trying to be critical, but I really do care about that because I think patients, medicine or psychology, it's not perfect. We don't have 100% success rate, but not only in mental health, it's in physical health too, in any other specialty. It's not when somebody have hypertension or diabetes, how many of them get cured or how many of them get 100% response or remission, but they do a lot better and they can function a lot better. So access to care, I have seen sometimes, doesn't always mean the best access to care. I think standard of care is not followed very well, in some circumstances, or a lot of circumstances. So, for example, I'll just give an example that will give. I think,
No, please
again,
do. I think the
yeah.
standard of care is very
Yeah.
important.
So a lot of the training in the DoD is some of it. Of course, there is psychologists that are doing all kinds of different psychotherapies, and trauma-based therapy is very important. Cognitive behavior therapy is very. These are evidence-based, means like there is clinical trials actually. Psychoanalysis, for example, there is no evidence base for that. I mean, there is no clinical trials to support it, but yet the DoD still trains psychiatrists to do psychoanalysis. It doesn't happen ever outside. That's the Freudian psychoanalysis. The other thing is, I mentioned there is not enough psychiatrists. Maybe it's the number, that's the number I heard, but maybe it's not exactly correct. So don't quote me in that, but there is definitely severe deficiency. And remember that also some of these psychiatrists gets deployed or whatever. The other thing is, if you go to a, if I'm going to be treated, or somebody going to be treated in a big academic medical center, there is a department of psychology, there is a department of psychiatry, there is maybe sociology. So the philosophy of this department help complement each other, and people get the best treatment. Like you're going, you have somebody have diabetes and they're going to an endocrinologist, the Department of Internal Medicine, endocrinologist to get the best treatment, and they go to a nutritionist, a dietitian to get the best treatment. So they get a holistic approach. But that doesn't happen in the VA or the DoD. And definitely, there is usually a one department that's headed by a psychologist or a social worker, which is great. But then there is very severe deficiency on the medical side that does it. And there is also still in our culture, not just in the military, it's in our culture that, maybe these stuff are not medical at all. But actually there is a percentage is medical. The complication with that is that most of us think black and white, think it's either social or not. But social and psychological things are important to be treated. I am always pro that. But I think the pendulum went on the other side, where we totally ignored any medical aspect, or at least of some people that might need. Some don't need that, and we ignore that. Some of it, as I mentioned, can be having a mental component. I'm not saying it's 100%, it's just a mental component. And anything psychologically can change things in the brain. So things can start environmental and change circuits in the brain, change neurotransmitters of the brain that it will require. I gave that example in a previous thing. It's like somebody have a car accident, they broke their arm. Well, it's an environmental thing, but caused a medical problem. And this broken arm needs to be fixed from not just the bones, but the vessels, the muscles, and the tissues. So it needs several specialists, not just one. So I think paying more attention to that and not ignoring. So I've seen many patients, will they go, okay, well, they need help. Okay, they are suicidal. So they see somebody, they do some counseling, but there might be underlying other things that might need, medical treatment or comorbid things that even hasn't been diagnosed. People pay attention to the suicide because it's scary, but they don't pay attention to the underlying cause. It's like having somebody with an appendix that you only treat the pain, but you don't remove the appendix. So the underlying problem continues to be there and continues to present at the top of iceberg, which is suicidal thoughts. And yeah, so I think this is a very important thing to pay attention to. I think the model for universities work better, where you have really strong presence for a medical and other mental health providers helping the patient, working together and communicating.
Yeah, that's a one of the things I hear you saying, and it's very in tune to a topic that we were getting ready to get into. We're just going to jump into it now. Is the different treatment modalities, the different clinical care settings. Unqualified folks who are very less experienced in providing care. These are all things that I believe are happening out there. in the underlying causes. Now, Dr. Youssef, I'd ask you a question on this and kind of educate us all, or at least me, because I'm thick-headed here. I've been through cognitive processing therapy. It triggered me. EMDR helped me. Spirituality helped me. Why are so much reluctancy in institutions, considering the VA, do not want to get into non-evidence-based treatment when it's like spirituality? It's a high demand cycle. 85% of the veterans are spiritual, they've claimed to be, and require some type of spiritual faith-based treatment if they were allowed in their training. I'm just giving that as an example. It's really the whole training period, whether that's prolonged exposure, EMDR, cognitive behavior therapy, cognitive processing therapy, and there's probably others out there I'm just not aware of. Why evidence-based, not evidence-based? What's your thoughts on that?
So, yeah, I mean, I don't want to say that everywhere is not evidence-based, but I think there is some lag if you compare inside from outside. Probably there is not enough providers. There is some lag in adopting evidence-based treatments, at least in some hospitals, whether VA or DOD. Maybe there's not enough providers. There's not enough knowledge. There's not enough continual medical education. Of course there is, but it's not the same rigor. So either treat these patients with that same level, or they should be treated outside. And it should be easy. I know they can be treated outside now, but I think it's very difficult for them. They have to get permission. It's very difficult. Spirituality, definitely. I think partly political, but also, frankly, but also I think there should be more research on that. I mean, it's very hard to get funding, for example, I was doing a spiritual study for PTSD. So, it's not only biological, incorporating this in psychotherapy if the patient is agreeable to that, for sure. And a lot of patients, one of our studies showed that 84% or so of veterans want spirituality incorporated in their psychotherapy, in their CPT, cognitive processing therapy or so. There should be more research on how to incorporate that and include it in the manualized way of treatment. And there should be more funding for that. Now, that's another thing I didn't address. I mean, since 2001, there has been no FDA approved medication for PTSD. So
Wow.
over 20 years, there is no. The only two things that's really approved is sertraline and paroxetine. That's the only two, and the others are off-label. Basically, there is less evidence, but just there is some evidence, but not a lot. And so there should be more funding for research, for more evidence-based treatment for suicide, for PTSD, and for programs like psychological programs, spiritual programs. There should be more funding for that. There should be more research over that. That's not happening with a fast enough pace.
Wow. Deborah, you have some questions that we have been sent in. Can you go ahead and address some of those questions? We'll take a moment here. Again, you're listening to Crisis in America, PTSD, Veteran Suicide Show, panel discussion on mental health, which is affecting our service members and our veteran communities very, very hard. In fact, it's an epidemic. Go ahead, Deborah.
Well, yes, I
some of
can.
those.
Yes, I can, Colonel. I would like to address this to Amanda. It has been my experience that we have had some really poor clinical care teams out treating the veterans. And I always remind them that we need a place of safety, mourning, and reconnection in that order for us to recover those, that the stages that the vets have to go through. What are strategies that you can address to train the clinical care teams? Because I know that you've had experience in that.
Oh man. Okay, so for the care teams, I think that a lot of this has to be individually based instead of a blanket base. because everybody's needs are different, everybody's situation is different. So I think that maybe it needs to be initially first looked at more individually without checking boxes, because every individual person is completely different. EMDR therapy, that does not work for me. The prolonged exposure, I could not handle that. Maybe I can in the future, but when I tried it, I couldn't handle it. There's so many different ways of getting the therapy that you need. But I think the problem is the information and the opportunity.
Scripted.
Right. People don't know what really there is for them to try. I think that the doctors, individual doctors, from my experience, I've been through a whole lot of different doctors, and I feel like this one focuses more on like this tactic of therapy. This one focuses more on giving you medication rather than sitting down and taking the time to do to figure out what kind of therapy works for you. I feel like most of it was box checking and opening a can of worms and sending you out the door. Hey, our 60 minutes is up. Sorry. You know, I think that there just needs to be a lot more options and a lot more options that are provided to us with the information behind it. Because I had to find this art therapy on my own. I had no idea that it was actually a therapy until I actually started doing it for myself. And I realized, wow, this is really great. I really like this. I'm really enjoying this. And then I was like, well, this is pretty therapeutic, art therapy, boom. And then I figured out that that's actually a thing, and I wasn't actually the genius that came up with it. So, but what always is at the top of my mind is getting rid of the medications, the chemicals, the medications. I am over taking all of those. I'm over it. I got off of, I was at 14 different pills a day at one point. I went down to 12, went down to 10. Now I'm at 5, which is a big step. It's still a lot of pills, but I don't need them anymore. I think they need to look at more natural approaches to things. There's a lot of different research that's out there, and they need to make that available to all of us, I think. I hope that answered the question. I kind of
That was great.
Amanda, could you tell us your website where you sell your jewelry, because it is incredibly beautiful and you make it for both men and women?
I do. Well, the website's really easy. It's just the name, beadpricks@gmail.com. BEADPRIKS. Use your imagination on that one. The name is hilarious to me. I know that it's
You got me laughing.
Yeah, see, you gotta use your
good old veteran humor,
right?
That's right. Foxhole jokes, man.
Colonel, do you have your bracelet there that she sent you?
I do have my bracelet here. If everybody wants to see what she does, this is my warrior bracelet, and the details, the fine stones and gems. This being handcrafted, according to Amanda, this was made just for me. And I think her heart and her efforts and her research, when she puts together a piece of jewelry, it is about you as an individual. There is no doubt, because when I read the history behind the way this was designed, you know, a positive person, I am a warrior. The characteristics of the gem itself, if you can't see it, you'll see the little cross that's within the brown gemstone. I mean, the fine detail that is a part of this is beautiful, and I thank Amanda for her work. And you should go onto the website. As hilarious as it is, it's actually got some nice. You got Father's Day coming up. You know, you got the 4th of July. You got Veterans Day, and you know, it's just a spirit of America right here, baby. And it's made by one of our panelists today. So that's
I really like sales too, so I like giving out discounts.
What a good plug, Colonel. God, love it. That's so good.
I was a
You
Shameless
deserve,
I was
you
a
deserve
marketing,
it,
I was
Amanda.
I was a
No, you deserve
marketing,
it.
I was a marketing major in college. So.
I appreciate it.
I'd love to chime in on what the doctor and Amanda were talking about, if that's okay.
Yeah, let's
Colonel.
go. Let's run. We're doing a great panel here. Let's keep it
Yeah,
going.
it's such a good discussion, and you guys are bringing up such good points. And you know, I agree with you, Amanda. The chemicals, you know, they're not for everyone. I can also agree with Dr. Yosef that you know, there are certain chemical imbalances that do require medication. You know, bipolar disorder, and there's quite a few different you know, things that I do agree with when it comes to that, especially like the different methods, the CBT, the EMDR. It doesn't work for everybody, like you guys said, but for some it does. And you know, when we talk about mental health, I think too many times we forget that it's its own body. You know, our brain, our mental state, it's its own body. So just like physical health, just like nutrition, where it takes balance and moderation and all these things, and a healthful diet, it's the same with treating your mental state. You have to do it in balance. You have to do it in moderation. What works, you know, for some, I think combining CBT with other alternative care programs, or you know, and doing it in moderation, where you're not completely overwhelming your system all the time and just focused on healing, because the more you focus on your healing and your mental health, the more you're reiterating that you have a problem, that you have an issue, instead of just living your life and trying to get through when the situations arise that you need to get through, when the crisis happens, you know. And that's what's beautiful about CBT, is that you know, it causes those triggers, Colonel. Like you said, you got triggered. It makes you like address it and confront it, and it takes you to a place where you can reprogram your brain on how you react to that trigger, and how and you can recognize it. But one thing that a lot of positive stuff has been coming out that I really want to address is the study at Purdue University that they did with service dogs treating PTSD.
Amen.
The one thing that all of these systems of care, the current systems of care, are missing is the element of love. And I'm going to be cheesy, I'm going to say it. We're missing love in EMDR and CBT, in therapy and counseling. Unless you have a deep inner connection with that person, there's no true love there. And so with service dogs, you know, Purdue University, I was actually part of this study where we wore a bracelet 6 months before going to training, and then I wore a bracelet 6 months after going to training. Some of the results that came out of this study were phenomenal. Lower overall symptoms of post-traumatic stress, lower levels of depression, higher levels of life satisfaction, higher overall psychological well-being, lower levels of social isolation and greater ability to participate in social activities, higher levels of resilience, higher levels of companionship, less absenteeism from work due to health among those who are employed. Like all of these things that, you know, I mean, I'm like getting emotional right now because this,
I love how you have this huge smile on your face.
because I got a service dog from this program, and it changed my life. I have not thought of suicide one time since getting this ball of love and fur that just completely changed my life. And it's true love. It's a bonding that no other therapy can give you. They're having tremendous success rates. They're expanding their program to Texas. It's actually, they're backing, the VA is finally starting to back it, and they're going to be supporting veterans with funding for service dogs. So it's huge. We're starting to see that. There's also MAPS, the Multi-Association for Psychedelic Studies. It's a federally backed study that has been studying the effects of psilocybin on veterans with PTSD and traumatic brain injuries. They're having crazy success too, and it's all natural. It's, you know, I don't necessarily want to get too much into that, but you know, there are these alternative research and therapies coming up that we should really start to take notice and start speaking out about it. And you know, that's what it takes, is the education.
Yeah, you bring up a great point with K9 for Warriors. I believe that's who you're talking about.
Yes,
today.
sir.
K9 for Warriors, folks in America, just a plug for them. And it's the way they are changing the conversation around veterans with service animals, specifically dogs here, and what that has done to their overall mental health well-being. K9 for Warriors, look it up, because it is changing the discussion. And that's what we're here today to do. Change the discussion. Change the way we look at things. You know, like Edison, like I believe Ben Franklin said, or Edison, one of those dead inventors out there, stated that we keep on doing the same thing over and over again and expecting different results. That's the definition of insanity. So let's take a sane approach, a logical approach. You've heard it from Amanda, Jan, Andrew, and Professor Youssef on this very subject. So
I totally agree. I think this is very therapeutic, and the VA had done a good job with that. And I think a multimodal treatment is helpful, and individualized treatment is helpful. What works, as you said, and all of you said, that what works for some person doesn't work for the other. There is definitely individualized difference. PTSD is probably not just one disorder. It's probably many different things that we just lump it under that umbrella because we don't have a way really to test it, you know. And so, yeah, I think following the personalized, individualized person, see what works for each person, and combining it in a holistic way is great. And I agree that most people with PTSD say if there is no other comorbidities, probably don't need medications. I always tell my patients that sometimes psychotherapy and other modalities is helpful. Even depression, you know, some people with depression might need medication, but some others just can do very well with therapy, counseling, or even sunlight or being exposed to nature. That is very therapeutic too, say for depression. So looking at all these options are very important, and what works, then go with it for sure. Considering the person, considering the severity, considering the type, consider even the type of the trauma. So that's all very important.
that's great. Great. Deborah, we have some more questions from our audience.
We sure do. This is to Andrew. I'm hopeful for our military, hopeful for our veterans, and hopeful for our success in ending the veteran suicide. What we would like to ask you is, what are some of the programs and services that you provide for our veterans, especially our homeless veterans?
Well, so I think it comes back to that mentorship and you know, getting them when they need it the most, and getting them the right support, because even our homeless community is so different. Everybody's so different. Their needs are so different. Some really want to get off the streets and get back into school and get a new career. Some really just want to get their benefits and be in a warm place in the winter. And then there are some that really enjoy the freedom of being on the streets and you know, outside of society, unfortunately. And what I'm able to provide right now is that element of support that they need for the guys that want to get off the streets, for the guys that fell into hard times, that are, you know, at the highest risk of suicide, because they're in a place where they don't want to be. So if we locate these guys, or they find us. So far, I've only dealt with men, not by choice. It's just that's, you know, men have found me. So I'm able to be, you know, really connect with these guys and you know, share my story, because I've been homeless. You know, I was injured and homeless and no real path, no ambition. And no, I wasn't in the VA system. I didn't have benefits. I didn't know I qualified for benefits. I was forced out of the military because I was self-medicating for PTSD and all the things we discussed. So, you know, for these guys right now, because we're still in the process of getting our first house, I'm able to get them into a shelter and get them a permanent bed. We have good relationships with all the local shelters, and anybody can do this. Just, you know, make a connection with the local shelters, let them know you have veterans that you're trying to get off the streets. This could be a national program right now if everybody just started volunteering and putting as much energy into it as I do. But you find these guys, you help them, you pick them up, you get them over to a permanent bed at a shelter. And permanent bed means that they can't get kicked out. They you know, especially if they're looking for jobs. I get them right over to the CRC, the Community Resource Center, or the VRC, the Veteran Resource Center, whatever's in your local area. And then we get them applying for their HUD-VASH. And the HUD-VASH is it's an agreement between HUD and the VA where they're able to provide semi-permanent housing for these guys and get them an apartment. We also have a relationship with the VOA, the Volunteers of America, in Denver, and they support them with a security deposit. So between the security deposit and the HUD-VASH, these guys get a new apartment. And then through the community, we get donations of furniture, mattresses, and everything they need to fill up their home with all the house items that they need to be pretty self-sufficient. And the last guy we helped was really just inspiring. He was able to go out and find himself a job while he was in the shelter. He used that opportunity because every day before that, he was just scrounging up change on the side of the road and asking people for money just so he could get a room to get off the street and get out of the cold. And that was his whole day. He didn't have time to go get clothes and go get a job and go do interviews and look presentable. And so, you know, we have another relationship with the thrift store out here, and we were able to give them vouchers so they can get new clothes, new suits, spend a couple $100 on them. And then, you know, they get 3 meals a day at the shelter. And within about 8 weeks, they get their permanent housing. So it's a hard process, right? You know, it's really only for the guys that really want to get off the streets, that want to change. He's about to get his disability back pay. He's got a year of back pay coming to him. So there's, you know, it's hard, but you know, we're able to do it, and we're in the process of getting our first house so we can eliminate that shelter. So we'll get them off the streets, put them in our house, and then they'll wait out that 8 weeks in a place where, you know, people love and support them and care about them and cook for them and just help them with everything they need. And then the mentorship side, they have to have a mentor that helps them get through this process. Like that's the key. Otherwise, if, you know, because when they get that apartment, they're going to be back by themselves. You know, that's the biggest thing that causes this isolation, is when you get out of the military, you lose that camaraderie, you lose that brotherhood, that sisterhood.
Great points.
All of the things that we have in the military. I mean, we all bleed green, right? And then when we get out, we don't have any of that. We have to go find it. We have to, hopefully it finds us. And especially if you're not in the VA healthcare, if you avoid that, like half of our vets do, then you're not really exposed to the veteran community. And you end up isolating and trying to connect with people that just will never get you and never understand what it's like to be a vet. So
what a great endeavor. Andrew, could you tell us how, if people want to make a donation or get more information, that they can contact you?
Yeah, absolutely. So personally, you can contact me at andrew@housesforwarriors.org. That's our website, housesforwarriors.org. And you can find us on Facebook, Instagram, at Houses for Warriors.
That's fantastic.
I have to echo Deborah's statements. What a job of setting a example for other local communities to follow. I mean, America, you know, the statistics we hear on this from the Department of Housing and Urban Development, they estimate almost 41,000 veterans are homeless at any given one night. Just put that in your wheelhouse. And a study from the Pew Research as well, the National Coalition for the Homeless Veterans reports there is at least 1.4 million at risk at any one time. And so we know you don't have security, you don't have economic security, physical security, emotional well-being, spiritual well-being, all these things add up. And so what Andrew's doing is in his community and state, and he would go national. I mean, this guy's a dreamer with great vision and set realistic objectives and goals.
And a big heart.
And,
Big heart.
Yeah, and yes, like Deborah says, in a gigantic heart to serve
Thanks,
those
guys.
that are less fortunate right now as they're coming off. Again, remember, when they come off active duty, Andrew said it so quickly and so correctly and with conciseness, they're coming home without that camaraderie. They get into this isolation mode. Then the no job comes in, and then no housing. And the next thing you know, you have someone teetering into that 22 suicides a day. And Andrew's stopping that right dead track, what he's doing in Colorado.
We all are. Everyone in this panel has such a big
Yeah.
heart. I wouldn't be here without you guys. So
Yeah. Thank you very much. Deborah, how about another one?
Okay. This is, let's see, this will be for Professor Nagy. Okay. There is one thing that we have noticed about our veterans and our military members that are still serving and our first responders who are suffering from PTSD and or moral injury, and that is forgiveness. Whether it is because they have taken another life or they survived a mission or incident and their battle buddy didn't, so they will have guilt that maybe they failed their job and it resulted in death, injury of their friend, or an innocent bystander, like non-combative, maybe, for example, women and children. What does forgiveness look like? And how is one forgiven through spiritual healing? I think we lost Professor Nagy. Does somebody else want to answer that question?
I'll answer it if you can ask me one more time.
Okay. To shorten it, what does forgiveness look like? And how is one forgiven through spiritual healing? Because we've talked about how that when that's incorporated in all the other areas of PTSD and mental illness, what does that forgiveness look like? And I know that you have used your jewelry making to facilitate that within yourself and to reach out to other people.
Forgiveness is pinnacle, in my opinion. I think that should be at the very top of everybody's personal growth healing list. I think is to look at first forgiving yourself by understanding that you are forgiven. You're forgiven by God, and that's what matters. That's what matters. And
amen.
the second most important is forgiving yourself. And I think that is probably the hardest one to do. Even forgiving other people is hard, but I think forgiving yourself is so hard because you're so hard on you're your own worst critic. That's what I like to tell my kids. Like, oh, I'm not really good at this. I'm not good at that. I'm like, well, you know what? You're your own worst critic, and I think that you're doing great. So forgiveness, to me, it looks like acknowledgement, I guess, would be a good word for it. You have to acknowledge your difficulties. You have to acknowledge your failures or shortcomings. But like we all learned in the military, it's adapt and overcome. you can mess up, you can have done this or that, and you can feel bad for yourself and wallow in your self-pity, but that's not going to do anything. You have to pick yourself up and keep on with the forward movements, because as soon as you start letting yourself stagnate in your self-pity and all that, then you're just going down. You're circling the drain, and that's hard to see yourself do. It's something that I think other people see before you. But forgiveness, like I said, very, very top of the list of things that you need to look at when you're looking to heal yourself. And you can't heal other people unless you heal yourself. That's another huge thing that all of us with the big hearts, I think that we have the tendency to overlook our own stuff because we're looking at everybody else's stuff. We're trying to problem solve for other people instead of problem solve for ourselves. So I'm looking at that for myself right now. I'm trying to work on that. I try to work on one thing at a time because I'm not as sharp as I once was, but you have to have the motivation, the self-motivation to be able to do this.
Beautiful, beautiful answer.
I would like to, I think that was great. There is no other statement better than what you just articulated. My belief in forgiveness, and it's just my own story, folks, is something I would never do because I held myself to a high standard. And what happens as I learned through my treatment is that we are taught almost to be perfectionists in our jobs. Failure is not an option, right? That's the mantra that you constantly hear. And when you're in life and death situation with your buddy on your left and your right, you can kind of appreciate why we have to make adaptive decisions, but perfect decisions because our buddy's life depends on it. And then we have moral displacement. Killing innocent women and children is not a abnormal thing. It's normal, and it sucks, and it's painful to watch. I don't care what side of the battlefield you're on. For this American, and I could probably speak for my other Americans here, that it is troubling to the soul. It's a deep wound. So forgiveness is learning to say, Mike, you're okay. You've done well in your life, and you did the best that you could do with the God gifts that God gave you. And he only put you in that situation because he knew you as a child of God could do it. That's where I see forgiveness, where I have to let go of the pain and suffering that I witnessed, that each of us have witnessed on the battlefield or off the battlefield. I don't care what it is, whether it's a death or a trauma of all different degrees, military sexual trauma, trauma with your boss. Maybe you made a mistake in the battlefield and you killed somebody accidentally. America, you need to know forgiveness and give us encouragement when you're out there. Just like Amanda stated, giving her encouragement to her child, these daily aspirations, these gratitude lists, they're all important because at the end of the day, we're not horrible people. We were just put in a horrible situation.
I'd love to piggyback on what Amanda said too, if that's okay.
Yeah.
When you said healing yourself before trying to heal others, I actually thought that was the case too. That you actually you just like love. You can't love anybody unless you love yourself. You can't offer healing. But then at some point I realized that, all of that stems from ego, to think that we have the power to heal other people when in fact the only thing we have the power to do is to help them heal themselves. Just like you're healing yourself and I'm healing myself. Like I think forgiveness comes down to is actually a responsibility. in order to achieve the things that you want to achieve in your life, in order to move past it. Just like with any business that you start, or any, you know, big dream that you have to change the world, it requires action, it requires not giving up, it requires moving through the hard stuff, the traumatic experiences that impact your business and your way of life. And but really just taking responsibility, I think, was key for me to, you know, once I became responsible for it, I owned it, I was able to forgive myself, and like I said, moving forward, you can't heal other people. There's no way. Like, there's no way anybody can offer healing to someone. You can only help them heal themselves. You can only help them by giving them the tools, giving them that new CBT, that new cognitive behavior, the new way to interact and address triggers. And that's, you know, I feel like that's what it really comes down to. And it's important. It's a necessity. Like you said, it's pinnacle to growth and maturity, and, you know, adapt and overcome, like you said.
Yeah. I think it's the analogy of, you can lead a horse to water, but you can't make them drink. You don't do the legwork for these people, you can provide them with the resources.
Exactly.
And you can show them the way to do it, and you can show them the best route to take. You know, line up all the steps for them, but if they're not going to be the ones willing to do it, then you're not going to do it for them.
The hand up approach. Yeah, it's a hand up versus a hand out.
Yep.
Like, that's, the handouts don't work.
No, not at all. I agree.
You're on mute, Colonel.
Sorry about that technology here for me. Thank you, Andrew, for watching me out there. Hey, we got Dr. Youssef back here on live on air.
Sorry,
Deborah, you want to readdress the question, or Dr. Youssef, are you familiar with the questions being asked?
No, I got disconnected for some reason. Sorry about that.
Okay, Deborah, can you reread the question for Dr. Youssef?
I sure can, because I would love to hear his answer. And the question was, there is one thing that we've noticed about our veterans and our military members that are still serving, along with our first responders who are suffering from PTSD and moral injury, and that is forgiveness. Whether it be because they have taken another life, or they've survived a mission and their battle buddy didn't, and they have guilt and think maybe they failed their job and it resulted in the death, injury of a friend, or perhaps innocent bystander, non-combative, maybe women and children. What does forgiveness look like, and how is one forgiven through spiritual healing?
Yeah, I heard great answers from the other members, and I know this is very, very tough. This is very tough, but it's also not addressed in any treatment, whether medical or psychological, or because it's only can be addressed in social things. Like, forgiveness is not part of the DSM criteria for PTSD or any other, and it's more of a spiritual thing, but it also is very important, and it can impair healing, and it can impair treatment, and it's very important. So spiritual treatment has a big role for that. Whether this spiritual, we can call it treatment, we can call it healing process, you know, through clergy, through counseling, is very important, and that's related to, we have published several papers on moral injury. It's related to moral injury too, because it can cause a lack of forgiveness from either side, or forgiving ourselves can cause a lot of injury that cannot be addressed with medications, cannot be even addressed with psychotherapy. It's different. And as I said, we published several papers, we did several studies on that, but again, I think the field is still grasping that importance. I mean, it's very, it's a common sense, but sometimes things doesn't get incorporated into clinics or VAs unless it is research to which can be helpful, but also through just the regular channels, different, according to the person's own faith. I think tapping into that help is very important through clergy, through the scriptures, through readings, through friends, support, love, as Andrew mentioned. All that is crucial.
Professor, how can people contact you if they have questions or just want to reach you to be able to make comments about our show today?
I'm actually definitely the email is a possibility, but I'm actually in the, I work some with Augusta University, but in the process of transitioning at Ohio State University. So I will be on the faculty soon at Ohio State, and I
Go
will.
Buckeyes.
Yeah, and definitely in our psychiatry department, we will be happy to help. But also, if there is, any other things, I'm happy to receive emails at my email and see how can I help.
Oh, that's wonderful. Thank you so much.
Dr.
All
Youssef,
of
you're
our
gonna have
panelists.
a friend there in one of our not our panelists, but our outreach service coordinator and special advisor, Rick Brown. I'm not sure if you met him yet, but he's part of our team. He's right in the Columbus area. So we look at enjoy our future with you more on a hands-to-hands basis, if not to say the least.
That's great.
Thank
I
you.
think we got acquainted, with Rick a couple of times, and we, I'm editing and writing a book, different chapters, but it's more for research on the epigenetics of stress disorders, PTSD and depression, trying to look at that, which is things that's not genetic, it's things that's actually changed by the environment. And I think research on that can lead to not just treatment, probably even prevention, which will be great. Understanding that things that's above the genetics that can be turned on and off due to environmental circumstances or trauma. This book should be out by the end of this year or early next year with Elsevier. It's more it's more of a technical book, but there is chapters that are less technical. For example, we have chapter about Tesla. Tesla had actually some post-traumatic symptoms, and so I wrote a chapter on that with one of my students, and we have we're planning to get one also for public.
Well, sign me up for a copy, sir. I would love to have one.
Sure.
Me too.
Great.
Go blue, by the way. Sorry, Colonel.
I thought you were. I remember you're from Michigan originally, even though you're not there now, right? So you're
Right.
a Wolverine fan, of course. You're the Go Blue, and we're the
Go
Go
Blue.
Bucks. And my
Mhm.
son's a Penn State grad, so my family is spread across the Big Ten. So, well, we all love each to our own, right?
That's an interesting family gathering.
Yeah. So, hey, we're running to the end of the show now, but this has been a great dialogue. I would like to open up for any more questions, Deborah. If not, we'll have our final thoughts from each of our panelists. Maybe unmute Deborah.
I think that we have answered everything, more or less, but the combination of all three views from each guest has been phenomenal. And I just really appreciate the different views because it's been really an eye-opener.
This has been great. This is going to be a great dialogue that we have. It's going to be a living document, folks. It'll be on our KGRA radio station Sunday from 5 to 6. We'll put that out on our website, spiritualwarriorfoundation.us, and other platforms that we have with KGRA radio for all our audiences to dial into. Before we leave, though, I can't be remiss to give each one of these panelists, first of all, a round of applause and thank you for your patriotism. Thank you for your great insights and your dialogue that you've had today. We are changing the discussion on suicide amongst our veterans and service members, and your input today was a testament to your own soul's journey and what you're doing in life to help another human being. It's great. Amanda, last words.
Well, Colonel, it's really an honor to be here and for you guys to ask me to be a part of this. I'm not somebody that I would have thought of to ask to do it, but it is really, really an honor. It's really a pleasure. I think that this dialogue has been incredible, and I think you are right. We are definitely changing. We're changing the conversation out there as we speak right now. I think that it's absolutely wonderful. Andrew, it's really incredible talking to you and hearing your opinions on all of these things and hearing what you are doing out in the community. I think that that's absolutely incredible, and I think that there needs to be more people like that out there to get our people off of the streets and the care that they need. I do want to get with you, and so we can figure out what to do with the female homeless veterans, because they tend to have a bigger difficulty finding shelters and stuff like that. They tend to have kids with them, things like that. I have some ideas for you with that.
Definitely.
Yeah,
Thank
Doctor, I think that the people in Ohio are going to have one of the best subject matter experts on their side out there, and I want to thank you on behalf of all of them for making the choice to go there and to have the passion that you do, and we all of us, I know I can speak for all of us, that we really absolutely appreciate what you're doing. Deborah, you're awesome. You're my new BFF.
Thank you.
Jan, you're amazing too. And I'm really glad that we could all have this conversation. Thank you.
Your family now,
You're
Amanda.
stuck with me now, y'all.
Your
You're
family.
Yeah, you're part of the tribe for sure.
We're stuck together.
You're on
I
mute,
think you
Mike.
said Andrew.
I'm always Andrew. Yeah, sorry about that. Final
That's
word,
okay.
Andrew.
Well, as always, it's a pleasure. I love getting on your show and being able to talk with you guys. And this was awesome being able to see you for a change. And Deborah, we're going to get you on camera next time, and we'll figure out Jan's too, so we can all get there. But Dr. Youssef, thank you for having your perspective in the panel and just or bringing your perspective to the panel and you know, an outside perspective that, you know, non-veteran, that's really key to be able to kind of bridge the gap between, you know, what's out there and what's needed based on, you know, like Amanda's and mine, you know, personal experiences being in the military and what we've seen and dealt with. And you know, coming from somebody who's been homeless, who's, you know, been able to navigate that system and get the benefits and, you know, go through this stuff, you know, I know it's not easy. So for anybody listening that, you know, really is ready to do this, I'd say, you know, it's going to be hard. It's going to be just like boot camp, but you can get through it. You can do it. You're going to have support. And I'll plug one more big resource that I give to everyone who calls me out of state, because I get a lot of calls from out of state, which is why this needs to go national. But the National Coalition for Homeless Veterans, sorry.
You're right.
National Coalition. Yeah, National. Let me write. I gotta write it. My brain doesn't work that way. National Coalition for Homeless. NCHV.org. NCHV.org. You can click Help for Veterans, and it'll give you a whole list of every state and all their resources. You just click on the state that you're in, and boom, you get access to every state resource that's on their website, and it's usually a good like 10 to 20 different resources. So first step, if you're ever experiencing issues, if any of our, you know, brothers and sisters out there that need help, you know, go to the National Coalition for Homeless Veterans first.
Thank you, Andrew.
And I love you guys. I love all of you. Thank you so much.
Thank
very
you.
much.
Thank you,
Hey.
everybody. It was really a privilege talking with all of you. I've learned a lot from each and every one, and it was great. And it was a great discussion, and I really appreciate and honor to be on the show. Thanks, Mike, Deborah, Andrew, Jane, and Amanda.
Thank you, Dr. Youssef. It's always a privilege to have, like Andrew stated, someone from your community involved in these discussions. Only then will we be able to get the traction that we need for our service member and veterans. So we appreciate your constant insight, but your subject matter expert, as Amanda said, to the issues at large. Deborah.
Yes, Colonel.
Yes, our questionnaires. Thank you for doing this for us today and bringing those questions to bear. Those are some deep, detailed questions from our audiences, and appreciate all your service and commitment to this show.
Well, it's always a pleasure, sir, because I learn as much as everyone else. And in my line of work that I used to do, I still am contacted by people with PTSD and with mental issues. And so I add this to my register of resources. And so I really appreciate getting everybody on the show, their time, and for bearing with us through the technical issues. And just say it has been one of the best shows that we have done.
Thank you. And lest we not forget our famous Jan. Jan is, just real quick, Jan, a plug for you, girl, is this person is connected to Americans, veterans, service members, and anything that could help us carry this message forward that we're having today. Jan Friedman. Jan?
Thank you all. It's a real pleasure to be part of this team. I'm so happy that I was able to connect with you. You all feel like family to me, and I'm devoted to our veterans each and every day in every way possible. Thank you so much.
All right.
Nobody volunteers more than Jan for my organization. I'm just going to throw that out there right now. She calls me every week to see what she can do. So I love you, Jan. Thank you.
Love you too, Andrew.
America, what we've been talking about today is a serious topic that's going on in our country, and that is the suicide rate amongst our service members and veterans, as well as our first responder community. Today, we had a panelist of guests. What this states is that we all have identified things need to change. The conversation needs to change. I hope that you heard some of that conversation today and changing your approach to ending this epidemic that's happening in America today with our veterans. We thank you for listening. We thank you for your insights through your questions. But most importantly, what we request of you is do a call for action and get a hold of Amanda, Andrew, or Dr. Youssef, or Jan, or Deborah, or myself to find out how you can do it. We showed you many ways today. Remember, innovative ideas lead to optimal solutions and saves lives. If no one has told you today that they love you, well, I'm telling you today, I love you. You stay strong, you stay vigilant, and you stay connected. And God bless our service members. God bless our veterans. God bless our first responders. And God bless the United States of America in world glory.